Hello, good morning. Make sure you type in your first and last name instead of owner or a phone number so that we can make sure you get hours. Like update it to say name. I see one that says owner. I see one that has a phone number. I see one that says Galaxy tab. Make sure that you come in with the first and last name. Hi, Sandra. Hi, Nando.
Good morning. How are you?
I am good. How about you?
Good, good. Nice to see you.
Good to see you guys too.
Nice, yes.
So I'm gonna wait a couple minutes for everybody to jump in, and what we're gonna be doing is reviewing face, torso, spine.
Hello.
Hi, Nando.
Hello. How
I
are
miss
you?
all you guys.
Oh, we miss you too.
It's been a long time.
Yes.
So I was having technology issues this morning as far as being able to see. I was gonna try to project on the board behind me, and it was pixelated and blurry, so I'm gonna actually try to screen share the diagrams that we're going to review. So once we see, wait a couple more minutes and see if everybody's up, then I'll see if I can't figure out how to screen share on this with what we're working on. So we uploaded a PDF to MindTap yesterday that are the diagrams that are on the actual ones that are on the test. So they were in your study packets, in the big packet. So what we uploaded were just the specific ones that are on the test that's due Sunday. So we're going to review those. We're going to go through the highlights again. So if you don't have these to write on and practice on, then I guess try to make some notes or something like that. Okay?
Sure.
Who all do I have on? Hi, David. I see David is up. I think we've got as many as we're probably going to get on. So let me see if I can figure out how to share the screen. I'm new to all this technology. I got like a 5-minute lesson, and then they're all down in Fort Myers. So hopefully I do not mess this up when I try to figure out how to share. Screen share, there it is. All right, I want to share that. All right, can you guys see the diagrams now? All right, so this is what we're going over. I don't know if any of you guys have printed these out or not. On the actual test that you'll be doing on MindTap, you'll see the diagram, and then there'll be, have you guys taken any of the tests yet where you click and a menu, a drop-down menu pops down, and that's where you select to fill in the blanks for the diagram? Have you, I don't know if you've seen that yet on any of the tests, you can give me a thumbs up. But what you'll get is so you'll get the diagram, and then it'll say the number, and then you click on it and you have a menu to scroll through. You might have to scroll up or down in the menu to see all the choices, and then you select them that way. So let's just kind of go over this. This very first diagram, the majority of it starts on page 170 of your trail guide. And what we're doing is we're just labeling the cervical vertebra is number 1. It's pointing at the ribs in number 2. It's pointing to the thoracic vertebrae in number 3. Lumbar vertebrae in number 4. The sacrum, and then the coccyx. And you'll have to stop me if you have any questions, because I don't know if you guys can see my face or just the diagram. If for some reason you don't get a chance to fill in all the diagrams, this recording will be posted like all the other ones have as well. So number 7 is the manubrium. And manubrium means handle. I like to think of the manubrium as the handle of the sword, and like the sternum is the sword. right? So manubrium is that top part of the sternum that we see. And then below that is the sternum. And then number 9, the costal cartilage, it's pointing to the actual cartilage. So as the ribs wrap around, they become cartilage as they come into the sternum. So it looks like part of the rib, but it's where the rib becomes cartilage as it attaches. And then number 10 is pointing to the lumbar vertebrae. And I'm going to scroll up just a little bit. And then that picture of the spine is in your trail guide on page 174 that shows the curves of the spine. So we know that the top is the cervical spine, and hopefully you guys remember the mnemonic of 7, 12, and 5 to remember the number of vertebra in each part. 7, we eat breakfast at 7, we eat lunch at 12, we eat dinner at 5. So 7 cervical vertebrae. And that curve of that part of the spine is considered a lordotic curve. And when you get into pathology, and you guys already have, so you probably learned a little bit about lordosis and kyphosis, where the curve becomes too over exaggerated and it starts to, like, lordosis in the cervical spine starts to give the hunchback. Kyphosis does, I mean. Lordosis in the cervical spine gives the forward anterior head tilt. Lordosis in the lower spine gives that really deep arch that I know you can't see. So number 12 is thoracic spine, 12 vertebrae in the thoracic spine, and that is a kyphotic curve. And then 13 is the lumbar vertebrae or lumbar spine. And you'll actually see on the answer key the word spine. So notice that here it says lumbar spine, thoracic spine, and cervical spine, whereas further up it was thoracic vertebrae, lumbar vertebrae. It's pointing to the individual vertebra there, whereas at the bottom it's on the spine. Because if you mix those up on the test, it's going to mark them wrong. So make note that we're talking about the spine here at the bottom. Any questions on that diagram? Give me a thumbs up if it's okay for me to move on to the next one. Good. Good.
Good.
Good. All right. So now we're moving to the next one. I know some of you went over this in class with me too. So it's kind of just a rehashing. Don't want to zoom in too much. All right, so now we're looking at the first and second cervical vertebrae, our atlas and axis, which are different than the rest of the cervical. So on C1, which is the first cervical vertebrae, you'll notice when you look at number 1, we don't have a spinous process on C1. You can see when you look at it from the top in that anterior view, you don't have that process that sticks out. It just kind of comes down to that posterior tubercle, that small bump. We still have the transverse process, number 2, that sticks out to the side. And number 3 is the lamina. It's that bone area that eventually becomes our lamina groove further down. Number 4 are the superior facets. And a facet we know articulates with another bone. Number 5 is the facet for the odontoid process, the articular facet for the odontoid process. So that means that process that's on C2 rests right into that area. That's what allows that turning and pivoting between that movement that we get between C1 and C2. Number 6 is the transverse process. Again, looking at it from the top, you can clearly see those little side wings sticking out. Number 7 is the lamina. And then remember, foramen is the hole. So vertebral foramen, that opening in the middle that our spinal cord would run through. And instead of it being a lamina groove, when we are up in C1, it's an actual groove for the vertebral artery to come out. And then that little small hole in that transverse process is the transverse foramen. And don't forget that little box number 11. We call C1, or that first cervical vertebrae, the atlas. Good to move down to C2? All right. So C2, moving down, part of this is a little cut off for me. Let's see. All right, moving down to C2, we're starting with number 12. Now we have a spinous process. So that's what can help you remember to distinguish C1 from the others. It does not, but on C2, the axis, we have a spinous process now. And if you look at that anterior view, you can see how it sticks down. That process is that thumb-like or finger-like place that sticks out that we on a bone that we could probably pick up with our fingers. Number 13, it's just that vertebral foramen again. It's kind of hard to see the hole from that angle. And then number 14, what makes C2 different than any other bones is that there's that odontoid process, or the dens, that articulates with C1 that gives us that movement. 15, our transverse process, and 16, the foramen, the hole, where we can allow all those nerves to run through. And then 17, the lamina. 18, we call C2 the axis. 19, looking at those superior facets again that articulate with the bones above. 20, the dens. So we're just calling the odontoid process the dens for short. 21, the lamina. 22, looking at that spinous process again. 23, vertebral foramen. And 24, transverse process. So give me a big thumbs up if we can move on to the next diagram. If you need another minute or so, I'll give you another minute to finish filling it in. I got a thumbs up from Nando, from Sandra. If anybody else needs me to wait, unmute for a second and ask me to wait a minute. Are you good, Coral?
Yeah, I'm good.
Okay. All right, I didn't hear anybody ask me to wait, so we'll move on to the next diagram. So now after C1 and C2, the rest of the cervical vertebrae look the same. So we're looking at that. Is it better for you guys when I zoom it in a little? All right. So we're looking at that lateral view, posterior tubercle, kind of hard to see there, but a little bump in the back. And if we have a posterior tubercle, then it makes sense that we'll have an anterior tubercle. And then we have a canal for the spinal nerve. And next time you're in here and you get to look at skinny, you can see all those little nerves that stick out of the side. Our transverse process, again, it's kind of hard to see from this angle, but that's a little wing sticking out. And then our spinous process. Good on that part? All right, so now we're gonna look at that top view. So we can see that transverse foramen for number 6. And then we call that front part the body. Starts to get a little bit thicker, and it helps to protect the spinal column behind it, the spinal cord. Number 8 is that anterior tubercle that we were looking at from the side. And the canal for the spinal nerve is the arrow is pointing into that little curve inside there. And then we have the posterior tubercle right behind that canal for the spinal nerve. And now we're starting to see that lamina groove, that nice curve between transverse process and spinous process that happens. That's where like our spinalis lies when we learned about the erector spinae muscles, right? It lies right in that lamina groove, up close to the spine, up close to that spinous process. So 12 is our spinous process. 13 is the lamina. 14, we're looking at those superior facets again that articulate with the bones above. And then 15, transverse process, again, the TVP. Any questions? Good to move on? Yes? Thumbs up? Good to move to the next one? All right. So now we're going to look at thoracic and lumbar vertebrae because they don't change a lot like our cervical ones do. They stay the same. So we only have to really worry about distinguishing C1 and C2 from the rest of the Cs, and then all the thoracic are going to look the same and all of the lumbar. Now, what you'll start to notice as we zoom in on the thoracic is, look at that spinous process, number 5, how it starts to curve down. We learned that the thoracic part of our spine is the least movable of all of the parts of the spine, right? Because our ribs are attached to it and we want to protect that movement that's going on so that our ribs and everything that are attached to our sternum that protect all of those organs in there, our heart and everything, don't have a lot of movement. And you can see where that spinous process angles down, that it would restrict some of that movement. So that's a way to distinguish when you're looking at thoracic vertebrae, is by looking at the direction of that spinous process. So number 1 is pointing to transverse process. Number 2, superior facets, which will be easier to see when we look at that superior view. Number 3 is the body. Number 4, something that we have on thoracic that we don't have on any of our other vertebrae, are the costal facets, right? We know our costals are our ribs, so that's where our ribs articulate with that vertebrae, right there in thoracic. We're not going to find that anywhere else. And then 5 is our spinous process. 6, we're looking at our vertebral foramen. 7, transverse process. 8, lamina. 9, spinous process. 10, body. 11, superior facets. 12, that lamina groove. Are we good for me to scroll down? All right. Picking up with 13, we're down here now on the lumbar vertebrae. Look at how different the spinous process looks now that we're down on lumbar. It's coming back up straight again, and it's wider, almost kind of like a little paddle or rudder. So 13 is our spinous process. 14, our transverse. 15, the body. Looking at our superior view, transverse process number 16. Vertebral foramen 17, spinous process 18, 19 is the body, 20 superior facets, and 21 lamina groove. Good to move on? Yep. All right, and remember this is recorded, so if you need to go back, if you haven't had a chance to print these out, you can go back and listen to the recording. I want us to have a chance to review our highlights as well. So now looking at the ribs and looking at those joints in the ribs, and if you have any questions on those, this diagram is found on page 173 of your trail guide. We're pointing at the first rib, and then number 2 is pointing at the second rib. Number 3 is pointing at the space where that costal cartilage comes to the sternum, and we tend to name joints after the 2 pieces that come together, so it's called the sternocostal joint. The next one is where the costals come with the chondrule, which chondrule we know is a word for cartilage, where those 2 come together, same thing, naming the joint after the 2 places that are coming together, are the 2 parts of the anatomy, so it's the costochondral joint. Costal rib, chondral cartilage, where they come together. We're looking at the body of the sternum for number 5. And number 6 is that costal cartilage, where it becomes cartilage as it wraps around and attaches to the sternum. Number 7 are the true ribs, 1 through 7. 8 are the false ribs, 8 through 10. Sometimes you'll see people label the false ribs as 8 through 12. For our purpose of the test in our textbook, we're saying the false ribs are 8 through 10. The floating ribs, the ones that don't attach, are numbers 11 through 12. Ribs 11 and 12. And then coming into the sternum itself, breaking the sternum down. The very top, and you can feel this with your fingers, when you find the two bones of the clavicle, that little space right in between is the jugular notch. That little dip right there. And then number 11, the manubrium, the handle of the sword. So think of the sternum, if you're a Game of Thrones fan, think of the sternum. The manubrium is the handle. You have the sternal angle, which is almost like a little suture that comes between the manubrium and the actual body of the sternum. So 12 is your sternal angle. 13, the body of the sternum. And 14 is there, the articulation with the ribs, the costal notches. I would write down both. It is articulation with ribs on your test, I believe, not costal notches, but I would know both. On MBLEX, they might ask you about some costal notches. And then 15 is the xiphoid process. That is the point, the tip of your sword. So you've got your manubrium, the handle, the body of the sternum is the sword, and that xiphoid process is the point of your sword. Give me a thumbs up if it's okay to move on to the next one. Good? Say no if I'm moving too fast. All right, so let's go over some muscles, you guys. So number 1, semispinalis capitis. And what do we know about the word capitis? If somebody wants to unmute and say it, you can. Capitis means head. We put a ball cap on our head, so that's the way to remember capitis, right? If you see a muscle that says capitis, look for an attachment on the head. Number 2, splenius capitis. Kind of hard to tell the differences in this scan. It scanned it a little bit dark, but we're looking at, and hopefully in your packets, are you able to see where it's pointing to in your study packets?
Yeah.
Okay, good. And you can always look on page 189 as well of your trail guide if you want to be able to see the differentiation of where it's pointing to on those muscles. Number 3, serratus posterior superior. So we know we have a serratus anterior, so we've got a serratus posterior superior. And what do we know if we have a superior? We usually have an inferior, right? And you can see that serrated edge out on the side of serratus posterior superior. 4, iliocostalis, one of our erector spinae muscles. 5, longissimus thoracis. I don't know if you guys remember, and you can shake your head if you don't, that we have the 3 erector spinae muscles. I love spaghetti, from lateral to medial, iliocostalis, longissimus, and then spinalis. But then we get into those muscles and they're further broken down into smaller groups. So like longissimus thoracis is part of the longissimus erector spinae muscle. Number 5, longissimus thoracis, and we can see it's attaching to the thoracic part of our region of our body. I'm going to scroll up. 6, spinalis thoracis. It's pointing all the way in. Spinalis is the most medial, and it's the part that attaches around the thoracic part. And if you look in your trail guide on page 189, you'll actually be able to see all the little attachments there on thoracic vertebrae. Then we have our serratus posterior inferior, inferior below, and our internal oblique. All right, 9, we're getting into some of our suboccipitals here. We have our rectus capitis posterior minor. And remember, the minor's above the major, right? And then number 10 is pointing into the oblique muscle, and that is our oblique capitis superior. So remember, we're going to look for those attaching to the head when they say capitis. 11 is our rectus capitis posterior major. And then 12 is our oblique capitis inferior. 13, longissimus capitis. So we had over on number 5, longissimus thoracis. So these are both part of, in the I love spaghetti, the longissimus erector spinae muscle. They're just breaking it down. That is the capitis portion of it. Longissimus capitis. 14, spinalis cervicis. So it's going to be around cervical spine, right? 15, iliocostalis. 16, longissimus thoracis. It's just mirroring number 5. It's just showing a different cutaway of it for us. 17, spinalis thoracis. 18, transverse abdominis. And then that thin, wide tendinous sheath, right? That aponeurosis, thoracolumbar aponeurosis. Means it's in the thoracic lumbar area, and aponeurosis, we learned early on in muscular system, is a tendinous, flat tendinous sheath. Give me the thumbs up if we're good to move on. Good? All right. So now we're getting into those bones of the face. And I know I was in there the day that Dave went over this with you, and you guys went through all of this in the book. We're going to re-identify it for the test. Number 1, frontal. That is the frontal region. That is the frontal bone. 2, it's hard to see, is parietal. Remember that parietal wraps all the way around to the back of the head where that sagittal suture is, right? We only get to see a little tiny bit of it in this front view. And then 3 is sphenoid. And remember, sphenoid is that butterfly. It's one bone that goes all the way across to both sides, that big butterfly or moth-looking bone. And 4 is the temporal. 5 is our nasal. And it's jumping further in for number 6, the ethmoid. And then you can see that lacrimal, which is right around where our lacrimal glands, our tear glands are. Zygomatic is number 8. 9 is vomer. I always remember the vomer. Does anybody know who Voldemort is? No, Voldemort looks like he doesn't have any nose. His nose looks like that picture of the vomer, right? 10 is the maxilla, which is that upper lip to upper teeth area, and then mandible, that lower jaw. Any questions? All right. So from the back, we have that sagittal suture. It follows the sagittal plane. Now we can really see those parietals that we didn't get a very big view of from the front, coming around those 2 parietal bones. 14 is the lambdoid, Lambdoid suture. And the lambda symbol kind of comes up like a triangle with a little flare off the top, which would be the sagittal suture. That's lambdoid, is named after the lambda symbol. Then we have our occiput. And on our occiput, we have our superior nuchal line, attachments for lots of muscles there. You can just bring your head around there and massage that area. That's an area where we get a lot of tension. Then we have that external occipital protuberance, that bump back there. They used to say it was a sign of wisdom. Then they found out it was actually larger on men, and they had to say that it has nothing to do with wisdom. 18, mastoid process. And what I want you to notice, because a lot of students make this mistake and they think that the mastoid process is part of the occipital bone, and it's not. Look at that suture line coming down. The mastoid process is not on the occiput. Just make that mental note for yourself. I know I have seen that question come up in tests in the past. 19, we're just looking at the maxilla from behind. 20, the mandible. Any questions? Good to go forward? Yes? All right. So, lucky for us, the very next one, and you can work on this if you want to, you probably did in your diagram, has all of these that kind of go around clockwise that can be confusing, but we only need to know number 29. And that's all that will be on the test for this diagram is number 29. And 29 is the big hole, foramen magnum. Any questions? Can move on. All right. Here is our mandible. So we know coronoid and coracoid processes stick out, and coronoid or coracoid mean a beak-like, like a bird beak. So why they had to do coronoid and coracoid to confuse us, as Dave always says, why give something one name when you can give it lots of names and really confuse everyone? I just have little tricks that help me remember. This is the mandible, and the coronoid process is on the mandible. I think about the N in mandible and the N in coronoid. That's how I remember coronoid process, and don't confuse it with a coracoid. It's a coronoid process. 2 is the head of the mandible. And that little space, you can see I drew dotted lines. That little space is the pterygoid fossa. Well, you guys learned about the pterygoid muscles already. We know a fossa is usually named after the muscle that lies in that little indent. And then we have the neck. If we have a head, we usually have a neck. 5, we have that condyle. And again, I put little dots so you could see it's talking kind of like that little facet there, almost kind of like. 6 is our ramus of the mandible. 7 is that sharp angle down on the corner. We can always feel that angle on ourselves. It's really easy to identify. 8 is the body. And 9 is that mental foramen. It's that little hole that the mentalis, one of the nerves comes out of, that Dave was talking about that day. If you brought your fingers to the corners of your mouth and down, you'll know when you press on it. You'll feel it immediately. It innervates the teeth and the jaw and the muscles in that area. And then 10 is our base. And then dropping down. 11, our greater horn. 12, it's kind of hard to see from this picture, is our lesser horn, but it actually sticks up like a little devil horn right out of the bone. And then 13 is the body. Any questions? Good to go on? Good to go on. All right, I think we only have one left. The muscles of the face. All right, so we have our frontalis, and we'll go over those movements and things again too. We'll have time to review some of our, we'll have a lot of time to review our highlights, it looks like. Then we have the procerus, that place right in between the nose, where we get that 11 line. A lot of people get Botoxed right in there. Corrugator supercilii. And think about the eyebrow. Look at where that is. Cilli means hair. supercilii, so it's right in the eyebrow, the middle of the eyebrow region. Orbicularis oculi, so orbicularis is that round muscle. It is a sphincter muscle on our face. Oculi, meaning the ocular or eye region. Nasalis, on our nose, our nasals. Levator means it's elevating, right? Anguli oris, and oris meaning oral or mouth region. So levator, anguli oris. Then we have our zygomaticus major, 7. 8, our orbicularis oris, so orbicularis meaning another round muscle, sphincter muscle, oris, oral mouth region. Depressor, so if we had a levator that lifts, we have a depressor that pulls down. Depressor anguli oris. It's going to do the opposite action of that levator anguli oris, right? 10 is mentalis, and 11 platysma. Are we good there, you guys? Yeah. All right. Does anybody have any questions about those diagrams? No? All right, so I'm going to unshare and then we're going to go back through and go over highlights, and I'll just kind of talk to you guys about it. Let me figure out how to undo the screen share. Stop share. All right, can you guys see me now instead of the screen? All right. So, and I don't know how to change who I am or I am not seeing on this. Okay, so I'm going to go into page 168 of our trail guide. Does everybody have their trail guides handy? I may have some highlights that Dave did not have for you. So if you're tuning in to this this class, or if you tune in later, you'll want to pay attention instead of tuning out, because I kind of go through and add highlights once I kind of audit the tests. On page 168, this isn't so much a highlight, but something I usually tell my students is where you see the picture of the body over the flesh and the bones and everything. I like this view because we don't get to see somebody when we're massaging them via just the muscles and bones. We have to kind of look at them and then figure out where what we're working on is underneath. And one of the things that I like to do is, we know spinous process C7, if you look in that posterior view, that is an area we always want to try to avoid. That's where, if you come back here, you can feel that prominent bump. That's right around C7. I like to write down that that's around the t-shirt line. When you're working on somebody on a chair, C7 fall, and they're covered in clothes, that is right around the line of the neck of your t-shirt. So I write down t-shirt line because that kind of gives me a visual when I'm massaging somebody to know where C7 is. If I'm trying to get in really close, I give myself a little bit further, a little more distance when I'm right around C7 there. I'm a little more careful in that space. We're going to jump over to page 170, bones of the spine and thorax. And there's a highlight here. I don't know if you guys got or not, but when we're looking at the thoracic vertebrae, we know that it articulates with the ribs. What I want you to highlight is at the very bottom of that left paragraph, it is designed to support the weight of, we're jumping down, sorry you guys. We're jumping from thoracic vertebrae down to lumbar vertebrae. Highlight the lumbar vertebrae, which is located between the 12th rib and the posterior iliac crest. It's designed to support the weight of the upper body. Did any of you guys have that already highlighted?
No.
Okay. I know that that question is on one of the tests. I've seen it. So the lumbar vertebrae is designed to support the weight of our upper body. We're going to jump forward to page, give me a minute, bear with me a minute. We're going to jump over to page 194. I really like these pages. Each section of your trail guide has a page where it groups those muscles into categories according to movement, so that you can know all the muscles that do flexion of the vertebral column or all the muscles that do extension. And what I want you to notice is under flexion of the vertebral column, that both the external and internal obliques also flex bilaterally. That means if both sides, not you, we know if it's unilaterally, it's going to cause rotation, right? So I want you to highlight and put a little asterisk that under flexion, that the external and internal obliques both aid in flexion of the vertebral column. We jump over to page 196. We're going into our erector spinae group. And here you guys probably already have a lot of these highlights. The erector spinae group runs from the sacrum to the occiput along the posterior aspect of the vertebral column. What I want you to highlight is the last paragraph. In the lumbar region, the erectors lie deep to the thin but dense thoracolumbar aponeurosis. So they run deep. When you get down into the lumbar, they run deep to that thoracolumbar aponeurosis. When you're up in the thoracic and cervical area, they are deep to, highlight this, trapezius, rhomboids, and serratus posterior, superior, and inferior. That's another highlight for you if you didn't have it before. And you guys, I know Dave told you that I love spaghetti, right? From the lateral to medial, iliocostalis longissimus spinalis. I also like to make a note in my book here, because I've seen this on the MBLEX, even if it's not on this test, that the erector spinae group, anywhere you want to write it, if you choose to write it, are type 1 muscle fiber. They are postural muscle. We know that that type 1 muscle fiber means that it doesn't tire easily, right? Those fast twitch muscles, those type 2s that lose their energy really quickly, those muscles that we run and we lift and we do all of our day-to-day and those get tired, that's fine. But those postural muscles have to be type 1 muscles, or after only an hour, we'd be walking around like this, right? They have to be those slow twitch muscles that take longer to fatigue so they can keep us upright and tall. When you get to page 197, I want you, did he have you highlight that the action of the group unilaterally, they laterally flex vertebral column to the same side? Yes? Was that a highlight for you already? Same side, ipsilateral, right? So they unilaterally, laterally flex the column to the same side. So if one side goes, we're doing lateral flexion to the same side. And then he had you highlight extend the vertebral column, correct? Good. And then down under the spinalis, did he have you highlight origin or insertion on those? All right, so our origin, just highlight spinous processes. Under insertion, the second part, cervicis, because we've got thoracis and cervicis as part of our spinalis, right? We've got those two groups. I want you to highlight spinous processes of cervicals except C1. That's for the spinalis cervicis. Good. Flipping the page to longissimus. We're looking at, for longissimus thoracis, I want you to highlight that insertion. Lower 9 ribs and transverse process of thoracic vertebrae up the upper 5 thoracic. And you can write upper 5 thoracic vertebrae if you want. And I also want you to make note that the mastoid process of the temporal bone is where the capitis inserts, and highlight that. Mastoid process is on the temporal bone, not the occiput. A lot of students, when you look at that bone that goes across the back of the head, they think the mastoid is on the occiput. That suture comes down just inside of the mastoid process. So the mastoid process back here is actually on the temporal bone. And that's a highlight. Iliocostalis, we know we've got parts as well, thoracis and cervicis and lumborum. I want you to highlight the very last insertion on that, transverse processes of lower cervicals. That's the insertion for iliocostalis cervicis. And also, it's worth noting that the longissimus is the only one that goes all the way up to the head and has a capitis. Iliocostalis and spinalis do not have capitis. They do not go all the way up to the head. All right, on page 199, where it talks about palpation, I want you to highlight number 1. When your partner is prone, lay both hands along either side of the lumbar vertebrae. Locate the region of the lower erectors by asking your partner to alternately raise and lower his feet slightly. That is how we would palpate those lower areas of the erector spinae group. That's a good highlight to have. I think he gave you all the highlights you need on the transversospinalis group, right? On page 200, 201. I don't have any little notes there. Let's jump over to page 203. Did somebody have a question?
Yeah, I have a question. Did you say there were highlights on 200?
There were some. I don't have any of them with asterisks that are pointing out that I've found them on test questions, but do you need me to give you any of those highlights on page 200?
Yeah, if there is any.
Okay, so in that very top paragraph, deep to the erector spinae muscle group, etc., I want you to highlight multifidi, rotatoris, and semispinalis, and extends the length of the vertebral column. It's basically just telling you what those parts of the transversospinalis group are.
Okay. Thank you.
And On page 201, I want you to highlight the actions, origin and insertion of the semispinalis capitis. That extends the vertebral column and the head because its muscles in the back extend, right? It originates in transverse process C4 to T5, and it inserts between the superior and inferior nuchal lines of the occiput. Good? All right, page 203. So I'm just kind of recapping on Dave's lecture. If I get to anything that is confusing at all, let me know and stop me. That's why I'm kind of moving on without a lot of explanation, because you got the main lecture and we're just kind of reviewing for the test. But please, even though I'm doing that, stop me if you need to, right? Let me know. All right, so splenius capitis and cervicis on page 203. This is not a highlight, but the long splenius capitis and splenius cervicis muscles are located along the upper back, posterior neck, we know that. In contrast to the other back muscles that run parallel to the spine, they run obliquely, and you can see that angle that they run at, right? And we know obliques do some kind of rotation most of the time as their primary. I highlight the splenius capitis is deep to the trapezius and the rhomboids if you don't already have that. Those actions highlight, they rotate the head and neck to the same side. Same side is ipsilateral, right? Opposite side is contralateral. Unilaterally, they flex the head laterally to the same side. And then when they're muscles in the back, so when they're bilateral, they extend, they bring our head back, right? Of the origin, just highlight C7 to T4 and T3 to T6. That's the capitis and cervicis origins. I want you to highlight and put a little asterisk next to that insertion. Capitis is the mastoid process and lateral portion or outside portion of the superior nuchal line. That's an important highlight. Any questions? We're going to jump over to the suboccipitals on page 205. Highlighting that first sentence, the 8 small suboccipitals are the deepest muscles of the upper posterior neck. And my little trick, if you were in the class when we taught this, for remembering the rectus capitis and the oblique capitis, is they start with R's and O's, and I think of them where there are up here, they give us this kind of motion, and I think of a lion going roar, R-R-O-O, like a roar. And that's how I remember that they're rectus and oblique, those first letters. That's kind of my mnemonic. So rectus capitis posterior, I want you to highlight in that little box that they rock and tilt the head back into extension, kind of in that lion roar kind of position. And I want you to highlight the origin of all 4 of those muscles. Rectus capitis posterior is the spinous process of the axis, which is C2. Rectus capitis posterior minor, tubercle of the posterior arch of the atlas, which is C1. Capitis, oblique capitis superior, transverse process of C1, and oblique capitis inferior, spinous process of axis C2. And we're going to jump over to our page 207, the QL muscle, my favorite muscle to get stretched and massaged because I have so much lower back pain. Quadratus lumborum. quad 4, four-sided muscle. All right. And do you guys have some highlights on that page for QL? Yep. I'm going to go over those and I'll let you know which ones are really important in there. So, although it would seem it's the deepest muscle of the lower back, I want you to highlight the quadratus lumborum is strangely enough the deepest muscle of the abdomen. It is an abdominal muscle, right, that lies behind our spine. So it is actually a deep abdominal. We just access it through the back. I want you to skip down a little bit further and highlight located on the posterior surface of the thorax. So behind our obliques, our transverse abdominis and everything, all the way behind the posterior surface of our thorax. Important highlight there. Not a highlight, while the medial portion of the quadratus lumborum is buried beneath the thoracolumbar aponeurosis and the thick erector spinae, I want you to highlight its lateral edge is accessible from the side of the torso. So you can really work that area if you have somebody in side lying position. Like, we don't do side lying just for prenatal. We can really do some good work on the serratus anterior, the costals in the ribs, the QL, some really good stretches and stuff in side lying position. And it's really easy to access it if somebody's on their side. Action, I want you to highlight unilaterally tilt or elevate the pelvis. So we're talking one side, right? We're lifting the hip. It's called the hip hiker muscle for a reason. It's like that belly dance muscle. Can alternate lifting the hips like belly dancers. So laterally tilt the pelvis because we have that little bit of give in the hip. So laterally tilt and laterally flex the vertebral column to the same side. So we can pull our hips up or we can tilt the column. Both of those are important. Super important highlight, posterior iliac crest is its origin. And I want you to know that insertion too. Last rib and transverse process of first through fourth lumbar. That 12th rib right in here. Our last rib. That's why it hikes the hip up. If it's tight, it's connected to that rib and it pulls the hip up. And that's why you guys have seen me in class come in with my hand on that iliac crest and push the hip back down towards the feet to get a nice stretch in that QL muscle. Any questions? I want you to flip the page to 208. There's an important highlight down in our palpation. Do you see the box that has the little check mark in it? It says, as you palpate, be sure you are accessing the deeper tissue in the lower back and not just the superficial external oblique. Highlight, when your partner hikes his hip, can you feel the lateral edge of the quadratus contract? Can you distinguish between the edge of the erector spinae and the quadratus? So in other words, you would have them hike their hip to help you palpate that area. All right. I wish I could see myself bigger in the screen so I could see if you can see the board behind me very clearly. We're talking about the abdominals now. And I know Dave went over this with you. If you look on page 209, it's listing them superficial to deep, rectus abdominis, external oblique, internal oblique, transverse abdominis. I don't know if you'll be able to see what I'm writing or not. I hope you can. I'm going to come right in here. So we have can you guys see that or read that at all, or is there too much glare? You can, okay. only marker I have in here too. It's dying a little bit. Let's try this other one. Internal oblique. I'm gonna try to make this marker last long enough for at least this. Okay, can you guys see that? You can see what I wrote up there? So. All right, rectus abdominis, we know rectus muscles do what? You can just do the directions with your hands. Rectus muscles run up and down, right? Yep, obliques run at angles, and transverse goes what way? So I always do this next to rectus. A little arrow that goes that direction. Now, to remember your external obliques and internal obliques when you're looking at the body, if you're looking at the front of me and imagine I have a big E for external on the front of my body, and the arrow points to the bottom corners of the E. So I have a big E here, and the arrows are pointing to the bottom corners of the E. That's the direction of the external obliques when you're looking at somebody in anatomical position from the front. They're running downward this way. Internal oblique, I do the arrow at the opposite angle. Same thing, if I had a big eye on the front of my body and you drew an arrow coming towards the front of my body, this is the direction that the internal obliques run. That's always something that helps me. And then transverse. So I draw my little diagrams like that. And that helps me remember my fiber directions. The arrow pointing towards the bottom of the E. If that person is laying there with the E on the front of them, you know they're angling downward that way. Can I erase that? Yes? I can erase? All right. The other thing that I like to remind myself of when it comes into these abdominals is that all right, these pins are the pits, y'all. External, oblique, E, rotate. Am I going off the board too far over? External oblique, rotate to opposite side. So I remember that by E-R-O. I don't know if Dave gave you this little mnemonic to help you remember or not. Did he give you this mnemonic? No? All right. Internal oblique is even easier to remember. Internal oblique, rotate E-R-O. Rotate same side. IRS, like Internal Revenue Service. ERO, external rotate opposite side. IRS, internal rotate same side. That'll help you remember that for the long term, I hope, right? Opposite side, contralateral, same side, ipsilateral, right? So IRS, I internal, rotate to the same side. ERO, external, rotate to the opposite side. Those are some of my little cheats to help me remember the abdominals from superficial to deep. So on page 209 at the top of the page, Highlight, if he didn't already have you highlight, the revered washboard belly is formed by the multiple superficial bellies of the rectus abdominis. The rectus abdominis is the one that gives us the washboard or the 6-pack or the 12-pack, depending on how defined it is. I want you to flip over to page 210. Rectus abdominis, it's action. Muscles on the front do what? Flex, right? So it's action, flex the vertebral column. So if it flexes the vertebral column forward, then it's also going to tilt the pelvis posteriorly. So what that means is it's going to tip that front side of the pelvis up, which makes the whole thing tilt towards the posterior or posterior, depending on how you say it. External obliques, I want you to highlight those actions. Now we have an easy way to remember it. We know if one side's doing it, it laterally flexes to the same side, but it rotates, ERO, to the opposite side. And I also want you to highlight bilaterally, they flex the vertebral column. So they bring us forward into flexion if they're both going bilaterally at the same time. Those are all important highlights to have. Internal oblique, same thing, laterally flex vertebral column to same side. But we know IRS, it also rotates vertebral column to the same side. IRS, so the internals rotate same side, externals rotate opposite. And I also want you to highlight that bilaterally they flex the vertebral column. Under transverse abdominis, its main action, suck in the belly. Compress abdominal contents. Suck in the belly, suck up the belly, let it release. That's how you roll your belly. And really interesting too, this is not a highlight, but I don't know if Dave went over the pyramidalis down at the bottom of that page. Roughly 20% of the population does not have that muscle. It's kind of an interesting thing, right? And I did have somebody say that popped up on their massage prepper, their MBLEX, even though it's not on a highlight for our exam. Note to self, that muscle that 20% of people don't have is that pyramidalis. Any questions, you guys? We doing good? Yeah. All right, we're moving on to page 213. Is this review helpful? Okay, stop me if you have questions. All right, 213, the diaphragm, my favorite muscle, right? If you guys have been in any of my meditation breathing, then you know how much I like the diaphragm, and I talk about us stretching that diaphragm muscle so we can breathe nice, deep, long, calming breaths. We definitely need to practice that before we take our tests and our MBLEX, right? So we can stay calm and think clearly. I want you to highlight at the very top, the diaphragm is the primary muscle of respiration or breathing. It's also worth noting that it attaches to the inner surface of the ribs, the lumbar vertebra, and they converge at the central tendon. So we know it curves up like a parachute when it's relaxed. So when it contracts, it draws down, right? So action. Draw down the central tendon of the diaphragm. Right next to that, inhale. So that means when we inhale, the central tendon of the diaphragm draws down. Remember, that's what causes that vacuum that fills our lungs. That's an important highlight. And it also increases the volume of the thoracic cavity during inhalation, which would mean it would decrease during exhalation, right? See that little box off to the right? I want you to highlight that little box. An involuntary contraction of the diaphragm will cause air to rush into the lungs and the vocal cords snap shut. That is a hiccup. It's when air rushes in, our diaphragm gives us a little involuntary spasm, and it causes that air to rush in, which makes our vocal cords snap shut, and they're going, that's them snapping shut, is that hiccup sound. Let's flip over to page 214 for palpation. Under number 3, I want you to highlight, moving only as your partner exhales, slowly press and curl your thumb pads underneath the edge of the ribs. So what they're saying is, if your partner is breathing, you bring your hands to the edge of the ribs, and as they slowly exhale and everything sinks in, you can curl your fingers in under there and feel that movement of the diaphragm. Good? All right. Intercostals. We know those are in between the ribs. I want you to look at the directions of those fibers. In that diagram at the top right, you can see how the fibers go different directions, right? And it would give you an idea of which way it's going to pull, because we have internal and external intercostals. You hear us talk about the intercostals all the time, but internal intercostals pull the ribs down, depress the ribs. They help expel the air during exhale. Look at the direction of those internal intercostals. They elevate the ribs up and out. They pull up and out and extend them for inhalation. They also help stabilize the rib cage. So under actions, I want you to highlight, they draw the ribs. These are the externals. The externals draw the ribs superiorly, increasing the space of the thoracic cavity to assist with inhalation. So the internals do the opposite. I want you to highlight that as well. They draw the ribs inferiorly, decreasing the space to assist with exhalation. They kind of help squeeze the air out of the lungs. Any questions? Good? Good. All right. So we're moving on to page 216, serratus posterior, superior, and inferior. And we know they affect the movement of the ribs. Serratus posterior, superior does the elevation. If you look at the directions of the fibers in that little top diagram. And serratus posterior, inferior, look at the direction of those fibers. They help with depression of the ribs. Looking at those fibers. So that means I want you to highlight the action of the superior. It's elevating the ribs during inhalation. And serratus posterior, superior, it inserts to the posterior surface of the 2nd through 5th ribs. You can see that from the diagram there. So that's how it helps elevate and pull them. It's pulling that insertion towards the spinous process, right? To help lift and open them out. Serratus posterior, inferior, highlight, depress the ribs during exhalation. And I want you to highlight the origin on that one. Spinous process of T12 through L3, sorry. So if the origin pulls the insertion towards it, then we realize that that means if it's originating on spinous process and it's reaching up towards those ribs, it's pulling them down as its action, or depressing the ribs for exhale. Pulling them down and pushing the air out. The intertransversary, I don't really have any super important highlights there. You can look at the way they look. They intertransverse, sorry, they're in between the transverse. The name gives it away for you, right? See how they lie right in between the transverse processes? I want you to notice, because this may come up even though it's not a highlight for this test, that they're cervical and lumbar only. They're not in the thoracic, where we have less movement. And they're right in there between the transverse and spinous processes. On page 218, no highlights here, but you'll hear about a lot of muscles that attach into the ligamentum nuchae. We talk about that nuchal line on the back of the head, right? The superior nuchal line. You can see that ligamentum nuchae is kind of at that external protuberance and where it kind of lies. And you're going to find that that's an insertion point for some muscles. So I always like to point that out, because sometimes students will ask me, well, what is that? I'm like, well, we can kind of go over that and see that that's that kind of sheath right there. Page 220, thoracolumbar aponeurosis. I don't really have any highlights, but I want you to look over that as well. That is that tendon, right? You can kind of get a really good view of it and its area in the back there. I think that's all I have for spine and thorax. Any questions there? Does anybody need to take a quick potty or drink break for like 2 minutes before we move through head, neck, and face, or should we just go on through and get it done? I'm gonna just keep moving on forward then, okay? Get it done and finish the lecture? All right. So the skull is composed of 22 bones. That's on page 228. And those are the diagrams that you used to fill in those practice diagrams that you had, right? And when Dave talked to you about the hyoid bone, did he have you feel that bone? Like you find your thyroid cartilage, which would be the Adam's apple, come roughly like an inch above it and bring your fingers out this, and you can actually move that hyoid bone and feel it kind of click a little, and then become still and move your tongue and swallow. You can feel that hyoid bone move up and down, right? I think my first highlight is not really until I get to page, well, I want you to go to page 242. Again, a good place to see those muscles in groups. Which ones do flexion, which ones do rotation, which ones do lateral flexion, depression and elevation of the jaw, protraction, retraction, all that good stuff, right? It's a good way to see a whole group of muscles responsible for a movement. We're going to go over to page 244, the SCM or sternocleidomastoid, which we know the name gives it away, right? Does anybody want to unmute and without having to look at the origin and insertion, just give me an idea by the name itself, sternocleidomastoid? Anyone? Anyone? Sternum and clavicle, right? Cleidoclavicle, sternum. Mastoid, mastoid. Bam, the name gives us the origins and insertions right there in the name. So highlight, it's an important highlight. The origin is the top of the manubrium. We learned the manubrium is that top of the sternum, right? And the medial 1/3 of the clavicle out here, not lateral, but medial. And its insertion, mastoid process of temporal bone, right? So those are important to know. And then of course the actions: laterally flex the head, rotate the head contralaterally or to opposite side. Over under palpation on page 245, number 3, ask your partner to raise his head very slightly off the table as you palpate. I want you to highlight, rotate the head slightly to the opposite side and ask him to flex his neck. That is the best way to palpate the SCM. Have them rotate their head slightly to the opposite side and then flex their neck. So they'd rotate and flex, right? Any questions? All right, we're going to move to page 246, the scalenes. Can you hear me?
Yes.
See me? We have power outages here. Hopefully I didn't lose too many of you guys. Everybody here, you can check in with me? Yep. All right. Sorry about that. I think that's been happening quite a bit lately, hasn't it? At some point in time, it drops the signal. It's because we're all using it at the same time, trying to teach all the classes all the time. All right, so we're on the scalenes. I know Dave went into some detail on the scalenes with you guys. The scalenes are sandwiched between the sternocleidomastoid and the anterior flap of the trapezius. So they're kind of like, if you come this way, they're like right in here between this flap and here. During normal inhalation, they help perform the task of elevating the ribs, because if you look in that diagram on page 246, you see how they attach to first and second rib, right? So they also help with inhalation and stuff. I want you to highlight in that second paragraph, the anterior scalene lies partially tucked beneath the SCM, the sternocleidomastoid. So it tucks down in under that SCM muscle. I also want you to highlight in that last paragraph the large branches of the brachial plexus and subclavian artery pass through a small gap between anterior and middle scalenes. That's an important one. And I think he talked to you about thoracic outlet syndrome, right? When that brachial plexus gets pinched and you get the tingly down the arm and into the fingers. So while a lot of people will avoid trying to massage SCM and anterior scalenes, it's really an important area of tension to try to release, especially if you've got people that get the tingles. That's something he was talking about, people who like carry trays or painters overhead, but guess who else gets a problem with that? Us. We tend to do like this when we're massaging and keep all of this rotated forward, where the upper traps and the SCM and everything get in there and pinch, and we get those tingles in those first 3 fingers of the hand. So there are actually a lot of really good chair massage videos you can find online with a protocol for massaging for thoracic outlet syndrome. Something worth looking up, especially if you ever have clients who say they're getting those tingles in those fingers. So all scalenes are listed on page 247, and I want you to highlight the origins of all 3, anterior, middle, and posterior. Transverse process of 3rd through 6th cervical vertebra for the anterior. Transverse process of 2nd through 7th for the middle. And TVP of 6th through 7th for the posterior. And anterior and middle, insert on 1st rib, and posterior 2nd rib. And their primary thing is to elevate the ribs during inhalation. We talked about that. And flex the head and neck. Coming into that forward flexion, right? Those are the anterior fibers that do that. Any questions? Good. All right, let's move on to masseter. Page 250. So I don't really have a lot of highlights on this one for you. It is the strongest muscle in the body relative to its size. That's an important one to know. Also really important to massage. Just feel that masseter on yourself. I'm actually struggling with a migraine today, and it was a stressful day yesterday, and I can feel so much tension all in my temporal and masseter mandible area, which means I probably slept doing this. Like I probably slept clenched teeth from stress. So a good therapist would really get in and massage around temporalis, because we learned temporalis comes in underneath and attaches down to mandible, right? That mandible joint, mandibular joint here, TMJ, in there, temporomandibular joint, is where the temporalis and the mandible temporal bones come together. That's TMJ. The TMJD is the dysfunction there where it pops and creaks. So really is a good idea if somebody has headaches to add some temporalis and masseter massage in there. So over on the bottom of page 251, we're going to jump over to temporalis, looking at that picture where it comes into that coronoid process of the mandible. And I want you to highlight the actions. It elevates the mandible and it retracts. It pulls it back, right? Protraction, retraction. Retraction is pretty important to know. It pulls it back into place. And if you protract and retract your joint, you may even feel a little bit of clicking in that TMJ joint. TMJ joint there. I want you to also highlight its origin, temporal fossa and fascia. You can see kind of right up there where it attaches in that temporal bone area. Let's jump over to page 253. I know he talked about the suprahyoids and the digastric. I don't really have any highlights there for you on the suprahyoid, but I do on the digastric. I want you to highlight that action. Depresses the mandible when that hyoid bone is fixed. Remember he talked about that little tendinous sling that it comes down through? It depresses the mandible. And you can see that picture of why it would pull it down, right? Into depression. You're going to use your digastric when you see all the diagrams on your test and you go like this. And your uh-oh face, right? Except for now you know to practice them between now and Sunday. All right, we're going to skip suprahyoids and infrahyoids. I think Dave gave you all the info you needed on that. Platysma, page 257. I don't know that I have any really super special highlights on it either. You want to know the actions of the platysma. He went over that with you, right? Depress the mandible, tighten the neck, the fascia of the neck, drill down the corners of the mouth, right? Those are important to know. Do I have any other things I want to talk to you about? Occipital frontalis. I think we kind of went over the majority of these. Let's just kind of briefly go through them because we have time, right? So occipita frontalis, we know that's the frontalis and the occipitalis, right? Kind of coming together. We can divide them out or individually. And those occipital fibers we know kind of pull up the forehead in surprise and give us these lovely little wrinkles right here on our forehead. So raise the eyebrows is the action, wrinkle the forehead. Galea, we talked about the galea. That's this whole aponeurosis here. Pterygoids, on page 259, deviate the mandible if you're doing them from one side to the other. Deviation. And then bilaterally, both contracting at the same time, elevate, close the mandible, protract. Any questions about those pterygoids? Know your actions there. Muscles of facial expression. You guys went over all the muscles of facial expression and what kind of expressions they gave you, right? Orbicularis oculi, squint the eye, flutter the eyelids, right? We've got that center portion of orbicularis oculi, which is the palpebral part. Palpate means your heart palpates, it flutters. That's how I remember that is the palpebral part. My eyelashes flutter when I'm, have something in my eye. Levators are going to lift and to smile, right? Depressors are going to depress. Nasalis, crinkling the nose. Do you guys have any questions about the muscles of facial expression? Any of the expressions that they do? No? I'm just flipping through to see if I had any special highlights here for you guys. I don't really, that I see. Other structures? No, I mean, unless you guys have any questions for me, we've kind of reviewed all of the important parts. Oh, I see chat. See, I'm still learning Zoom, so I wonder if in this chat window there were any questions. From David, yes. 5G got flipped on, lots of body issues for most people. 5G, I don't understand. I don't understand what that means. Yes. That must be when we must be when we lost the signal, I'm assuming, is what those chats mean. All right, well, does anybody have any questions for me then at all for what we just covered? Are we good? Unmute if you have any questions. No, you're good. All right, David. You were in class, weren't you, David, when we kind of went over this, I think? You were here before that last little bit of time we closed? Yes, okay. All right, you guys, well, if you don't have any questions about those highlights, you understand these that were uploaded yesterday, the diagrams that we went over, are on your test that you will take by Sunday in a drop-down menu. I can tell you that the program that I used to create these tests, I actually typed them all in and created drop-down menus, and I wanted you guys to be able to do your diagrams, right? That it limits it to only 20. So I put in the instructions, but make sure you follow that not every single number will be down below, that you pay attention to the number. I tried to make sure I highlighted or bolded the number if I needed to, right? But pay attention to the actual numbers that are listed, because I may skip like a number 19 and give you 20 and 21 if I feel like they're more important. Other than that, it's good to see some faces again. There may be diagrams on the MBLEX. They won't be fill in the blank ever. They might have an image with an arrow pointing to a muscle and ask you a question about the muscle. It just depends. I've heard some people have, oh, somebody has migraines and flu-like symptoms. Oh no, who is Galaxy Tab A? I can't see a name. Whoever Galaxy Tab A is, will you write your name down for me? So Coral, yes, there could be diagrams on the Mblex.
Okay, thank you.
Hello?
Yeah, I was just curious because I've heard, some people say no, some people say yeah. So,
We have to remember there's a huge bank of like over 5,000 questions. So what 100 questions you may randomly get is going to be the complete opposite of someone else. I have heard that there are occasionally like a little picture and the question will ask you something about something in that picture and then you have to select your A, B, C, or D, but you're never typing or labeling. It's always multiple choice. But
okay,
that's why if you were in class and if you weren't, when you're able to come back in, I give you pages of the handouts, like your big handout that you get to fit your big workbook that you get to fill in for these. I give you guys copies of that where you can actually cut the muscle out, glue it on an index card, and on the back, write the name of the muscle. You can color it in, its origin, insertion, and on the back, write its name, its origin, its insertion, and its action, and start to identify the muscles just by looking at them on flashcards. So if you haven't done flashcards with me before, once we're able to get back here in the classroom and learn that way, that's something that I can run copies of and give you so you can learn the muscles by identifying them, especially some of the really important ones. It's good to have. So also 5G being used now and it can cause lots of body issues. Oh, migraines or flu-like symptoms from Sky. Okay. So when you log in, if you don't have your name, if it says owner or Galaxy Tab A and I can't figure out who you are, I'm not able to give you the makeup time hours. It doesn't go in the system. So from now on, when you log in, make sure you type in your name because I know Dave has not been able to give hours to some people if he could not decipher who you were just for the Zoom. The Zoom are the extra credit hours, right? They're not extra credit, they're overtime. Can't find my words today. It's because I have this migraine. They are makeup hours. That's what I was looking for. You get makeup hours when you're in the actual Zoom meeting. Your activities are your regular clock hours. If you're like, I can see Sandra and Nando and Coral says Coral, David says David, but if you could send me a message, if you're Galaxy Tab A or something like that, to let me know what your name is so I can figure out and make sure I get you your hours for being here present. Good.
Did you get my name?
Carla, where
I'm
are
on my
you?
phone. I'm on my phone, so I'm not sure if my name shows up.
Are you Galaxy Tab A?
No. Um, it said iPhone before, but I switched it to my name, but I don't know if it like shows up.
Let me scroll through. I have owner, I have Coral, I have David, I have Sky, I have Jay, I have Carla.
Okay.
I have one that's just a phone icon. I don't know whose phone icon that is. It's just a phone icon, but I see Carla, Sky, Sandro, Jay, David, one that says owner, Coral, Nando, Sandra. So if I didn't say your name, that means you're showing up as not your name. So
Do you know when we're getting our progress report?
I have no idea. Part of the problem is, and they were wanting to try to print them, but part of the problem has been trying to get everything in the system because everything is online for both campuses and it comes in at different times, right? Because things are due on a Sunday, and then you're on to something else. I know Dave was working on that. They're actually down at the other campus meeting, trying to figure out if the governor doesn't change the timeline, then we're reopening on the 4th for students who want to be here. Just like it was before we closed, distance learning will continue for those who don't want to be here, and it'll still be social distancing and no hands-on until that's changed. Lois Litvin is phone. Okay, Lois, thank you. Who is owner? Is owner phone? Email me privately. That way we don't have to stay on for a long time, and tell me if you were L. Polgreen at Sun State. I don't know if you'll be able to see it. Can you guys see that at all? L. Polgreen at sunstate.edu. If
Yeah.
you, okay, if I didn't say your name, please email me that you were in this meeting and what device you were using so that I can try to make sure you get credit for being here.
I have a question.
Okay.
So if we're still going to be online for whatever reason, are you going to be able to do like an MBLEX boot camp still?
I am hoping so. I've talked to Dave a little bit about that. They just now brought us in to participate in the teaching because they wanted to make sure they were able to get everything running smoothly. About I am pushing boot camp who need to do that. Speaker. Can I get that an error? Hear me? All right.
You were breaking up.
Says my speaker has quit working. It's good now. Okay. So I'm working on hoping we can get a boot camp. The thing is that if the testing centers aren't open, we want to try to time boot camp with testing centers. And we also have to figure out if you still have hands-on to do. Some of you still had like 13 or 14 massages left. Do we create an LOA or something until we can get you hands-on to stop everything once you're done with all your curriculum? So there's just those little details that need to be worked out. And once they figure all of that out, then hopefully we'll be able to bring a boot camp up. I know they're trying to schedule a boot camp. Just wait. I guess everything is kind of wait and see, right? All right. I'm going to say goodbye to you guys. Please message me. Message me if, I'm going to say to all, to everyone, please message me. All right. Thank you guys. I miss you. I hope to see you back in soon. And Dave will be teaching hip, leg, and thigh for you later this week. Okay?
Awesome. Thank you.
All right.
Thank
Bye,
you.
guys.
Bye.
I'm trying to figure out how to turn it off. Bye, Nando. All right. Bye. How do I stop it? End. There we go.